Good morning and welcome to the October Award Network webinar. We're going to wait a minute or two to let everybody come in from the attendee queue, and we'll get started in just a moment. All right, I think we are probably at critical mass to get going with this webinar for the Award Network, October 2024. I'm Joanne Spetz and I'm playing MC duties this week while Bianca Frogner, our chair of the webinar committee, is not available. So today we're going to have a webinar on the National Dementia Workforce Study. And Donovan Moust from University of Michigan is going to be doing most of the presentation, but I am also here to be involved in Q&A with him as needed, although he usually does not need any additional input from me. So it'll be really great for all of us to hear from him about his leadership of this project and what's going on with it. You can use this QR code on the slide to provide ideas for future webinars and also to provide any information about volunteering that you might be interested in doing with the Award Network. Next month's webinar is going to be on utilizing VR and robotics in dementia. And I think this is going to be a super cool topic and very interesting. So look forward to that November 6th webinar. Yes, that is the day after Election Day, and I'm sure that we will all welcome a distraction from election conversations in having this really interesting discussion about the future of dementia care in the technology world. We also are really excited to share that we have some updates to the Direct Care Workforce Data Compendium on our website. So you can go to our website and you will find all of this updated content thanks to the ongoing fantastic work of Lei Chen, who's our postdoctoral fellow, and Kyoko Peterson, who is our fantastic research analyst. They have added new resources and are continuing to do so. Especially take a look at the harmonized data set, which might provide a lot of variables for you that would be useful for the purposes of your own research to help streamline your effort in finding policy variables relevant to the direct care workforce. We also are really excited to announce that based on your popular demand, we are going to organize grant writing groups. We are organizing groups aiming for people applying for grants in kind of the February deadline time period and also the June timeline period. These will be 3 to 5 people per group, and you should anticipate that there would be a commitment of about 6 hours per week over 4 months, because honestly, if you're writing your first K01 or Kangaroo or a large grant to a foundation, that really is the time you should be dedicating to it. There'll be 2 different variants. Both variants of the grant writing groups would have 2 hours of synchronous group feedback, where during the 2-hour break you would have time to read each other's stuff and then to have a discussion period about how to make it stronger. So you wouldn't have to do a lot of reading outside of that 2-hour block. It would be mostly in that block that you do the reading. And then with the expectation that there would be 4 hours of writing time, and that will have an option of on your own writing time, or based on some grant writing groups here we've had at UCSF, that might be synchronous time. We've got groups here that basically socially agree that they are going to commit these 2-hour writing time blocks synchronously. They get together, they say hi to each other, and literally then turn off their cameras and are committed to writing. Some groups here do a Pomodoro method where you've got 25-minute blocks of writing and then a 5-minute break where you might turn off your camera and get your coffee and socialize. Other groups are just don't have a check-in until the end of the 2-hour block. So you can indicate whether you would prefer that commitment of the 6-hour synchronous, which is a nice way to put it on your calendar, or if you'd prefer just to have the 2-hour commitment. So for the February deadlines, we want to get these groups going pretty quickly. So you can sign up now. We'll have this on our website and be sending out an email blast within the next couple of days. We also want you to save the date for our GSA annual scientific meeting award meeting that is going to be at the Sheraton in Seattle. If you happen to be in Seattle and aren't registering for GSA, you can attend for free. You can just come to the hotel. The meeting is free. There will be a lunch provided. It begins at 1 p.m. There will be lunch then. And then there will be an optional no host dinner that evening for those of you that would like to have dinner that night. Bianca Frogner is our Seattle expert and is helping us identify a great place to go eat that night. Thank you as always to our webinar committee. Everybody has been providing such great ideas for future webinars and doing a fantastic job planning. I really appreciate everybody in here's work, and it's been just such a pleasure to get to know everybody as well. And thank you to my colleagues on the leadership committee for being partners in this program. We want to acknowledge the National Institute on Aging, and also, of course, the views expressed in the presented materials do not necessarily reflect the official policies of Health and Human Services or NIA. But we are really grateful for their support and for allowing us to bring the award network together. So without further ado, I'm going to stop sharing my screen and let our lead speaker take it away. I'll also note while he's getting his slides shared that there is the Q&A available, so you can type in your questions into the Q&A box, and we will answer those after the kind of formal presentation, but there'll be plenty of time for Q&A about this.
Thanks for the introduction, Joanne. There will definitely be plenty of time for questions at the end. I don't even think we have 20 slides here. So I'm not quite sure how I got the short end of the stick. Excuse me, not the short end, the privilege of being able to present today, because Joanne is my very capable and most important multiple PI on this project. But anyways, I'll talk and she'll hopefully chime in if there are questions that come up that she can help me answer. So a little background. For sure, I'm preaching to the choir with this particular group. So we know that the population of older Americans with dementia is going to more than double over the next couple of decades, in particular as the sort of bolus of baby boomers is aging and work their age up into their 70s and their 80s when dementia becomes very common. Costs of care for these individuals are quite high. And there's a really large workforce that cares for these adults. So as a physician, I'm sort of biased. And when I think about workforce, I think about, doctors' offices and hospitals. But obviously, working with Joanne and learning a lot over the past couple of years, this workforce is huge. And say the physicians and the nurse practitioners are sort of like the tip of the iceberg in the workforce that really cares for these older adults. So I've done work around kind of the sort of provider decision making around prescribing, like how do doctors decide to prescribe particular types of medications? You learn in medical school, a patient has an illness or a disease, and there's a particular treatment that you give that patient, and voila, everything is better. Well, the reality is that the care that somebody receives is largely determined by who's the clinician, who's the person that's caring for them. And while there's been lots of work focused on older adults as they age, on the family caregivers and care partners of these older adults, we know much, much less about sort of the healthcare side, the employed side of the workforce. Again, the workforce writ broadly. From all sorts of professions. So anyways, what's the National Dementia Workforce Study? So 2 years ago, late summer, an RFA came out from the NIA saying, again, there's been lots of research focused on older adults and family caregivers. We know much, much less about the sort of the supply side of the healthcare equation. That might be a contributing factor to this large variation in care that persons with dementia receive. And so it's this very large cooperative agreement funded by the NIA that actually we're basically at exactly our first birthday. The notice of award was the last day of September of 2023, and it goes basically for 5 years, so through August of 2028. And sort of the core of what the NIA was looking for was a survey of the paid dementia workforce. And that was really sort of not a lot of specificity in the proposal. And so part of our, say, my first conversations with Joanne was really figuring out like how would we define this? Who exactly should we be surveying and in what kinds of settings? But then the other critical piece was being able to link the surveys to outcomes data. So you can survey a physician who might say like, "Oh yeah, I do X, Y, and Z." But if you actually look at the care that they deliver, like the objective measures of the care that they deliver, it might be quite different from what they say they're doing. And so that piece was really important, being able to link the surveys to actual process and quality outcomes and costs of people with dementia. The other kind of uh, uh, bucket addressed in the RFA was really the overarching goal is to create a community of data users. So this is an unusual proposal for myself and I think for Joanne as well, where we're not proposing the research that's being done with this data. We're creating a data resource for other people to be able to use, to make it as broadly usable and of interest as possible. And so one way to help achieve those ends were a pilot study score that's led by Laura Wagner at UCSF to really help kind of accelerate and prime the use of the data. Again, the data is free for everybody, but the goal of the pilot awards was to have some funds out there to really sort of appeal to new data users. And ultimately, the goal is to help the NIA advance their research implementation milestones, which is sort of how NIA is being kind of measured on what they're doing with this enormous investment of dementia-related resources. And so specifically, there's this, I think, a relatively new milestone specifically related to the dementia care workforce. And so we would like to think, we hope that the work of NDWS will be really critical. What researchers do with these data will be important in helping NIA advance that specific milestone. So the team, Joanne and I are the multiple PIs for it. I have the privilege of working at the University of Michigan, where the Survey Research Center is really one of the nation's premier survey organizations. And so I've never fielded a huge national survey. But I happen to, work across campus from people who that is their expertise. So James Wagner is our survey methodologist. And then Laura Wagner at UCSF is on the team and leads the pilot studies core. And then my colleague Steve Marcus at Penn, who's sort of a secondary data linkage whiz. So we're the leadership team. We have a number of, I think it's on the order of 25 co-investigators spread across multiple institutions, including the Alzheimer's Association. I'll sort of in particular, note Cheryl Zimmerman, who's at UNC Chapel Hill, who has really critical expertise for us around assisted living communities. And then we have a number of consultants as well, including Kezia Scales with PHI. So it's a large team to do this complex project. Okay, so back to this, what are the surveys? Where are we focusing? So in our conversations in the fall of 22, when we were putting this proposal together, Joanne and I sort of talked through the what are the main settings of care? What are the main workforce groups that we would want to focus on? And so we started with the community clinician survey, and this is sort of a misnomer for a couple reasons. I think probably 20 years ago, this might have been called the physician survey, but that would be inaccurate and inappropriate because we know that if you think about the care delivered by the clinical care, say outpatient care, it includes nurse practitioners and PAs are a critical part of the workforce. And so we kind of started thinking about like office-based care, ambulatory care, but the truth is, so this is where we're also picking up clinicians who provide care, say in residential care settings. And they also might provide care in inpatient settings. So, so the community clinician survey is more accurately the physician, nurse practitioner, and PA survey, focusing on primary care, including geriatrics and hospice and palliative care, psychiatry, and neurology. Then we have three more organizational surveys, a nursing home survey, an assisted living survey, and a home care with a little asterisk I'm going to put by that one that we'll come back to, home care survey. We ultimately decided that within those three organizational surveys, we would focus specifically on so licensed nurses, LPNs, and RNs as sort of one bucket, and then the other one would be the direct care workforce, um, say nurses, assistants, medication techs. Um, Obviously, there's a whole number of settings that we're not including at this point, such as like respite care, hospice care, adult day settings. There are also other professions that we're not including: social work, physical therapy, occupational therapy. So we acknowledge it's a large amount of money, but it's not an infinite supply of money. And in particular, with sort of the startup phase, these were sort of boundaries that we felt were reasonable, say in our first couple of years. And then as things go, and if they go well, and if NIH chooses to continue this, we might maybe have the opportunity to expand the professions that we're including in the surveys. So the other thing is, we talk about kind of the four big surveys, but really it's seven, because for each of the organizational surveys, there's also basically a survey of the administrator for the organization that's participating. Um, and so there's kind of the four main surveys and then those three companion surveys. So just going through a little bit more detail now about each of those, the four kind of big surveys that you heard about. So the way that we develop the sample frame for the community clinician survey is looking at where, so billing clinicians in Medicare, where they bill. And so this was sort of a multi-step process. So the first thing is we used a claims-based algorithm to identify patients with dementia, dementia diagnosis recorded in their Medicare encounter data. So nurse practitioner saw a patient in the billing diagnoses, they included a diagnosis of dementia. Obviously, that is not perfect. There's lots of caveats around using claims data to identify dementia, but that's what we started with. So once we identify the patients, the beneficiaries with dementia, then we take a step up and we look at who are the clinicians who are providing care to those individuals. So we look at the billing records for all of those persons with dementia to identify all of the different unique clinicians who provided care for them. We included looking at prescription claims because we know that there's this phenomenon called incident to billing, where essentially a physician gets reimbursed at a higher rate than a nurse practitioner or a PA. So, say in outpatient care, you can have a nurse practitioner who really is sort of the day-to-day primary care provider for that patient. But to get the higher level of reimbursement, the bill will be submitted under the physician. But some people have published methods where they then look at the Part D prescription claims where the billing doesn't matter for those, and the nurse practitioner is the person that's writing the prescriptions. And so we looked at the Part D prescription claims to make sure that we weren't missing clinicians who were really truly the ones who were providing care. So then once we identified the universe of clinicians, we again limited it to our license and specialties of interest that are listed in that top bullet. And then we wanted to develop a little bit more detail about sort of the type of practice setting that these clinicians were in and the patient panels that they served. So we did a simple urban rural dichotomy, again, based on the location of the clinician. We looked at the panel size. Because a number of clinicians actually have relatively small numbers of individual persons with dementia. And we wanted to make sure that in the survey we represented people, again, across multiple different panel sizes. And then finally, as sort of a measure of the socioeconomic characteristics of the panel, we use the proportion of the clinicians panel that either had some point of Medicaid eligibility or what's called the Part D low income subsidy eligibility. That's a characteristic that's used by the guide model that some of you may be familiar for risk adjustment for the payment. And so we figured using an approach that CMS is using in other work was would make sense for us to use. And so that's how we built the sample frame. So we have our patients with dementia, the clinicians of the specialties of interest who care for them, the practice setting characteristics, and to develop our sample frame for the strata, and then sample our clinicians for the survey. Over 5 years, aiming for a sample size of around 20,000 physicians. The nursing home staff survey was similar in some ways where we used basically NDS assessment data to identify nursing home residents with dementia. We then looked at the facilities that they were in, looked at facility characteristics, urban, rural, demographics, to identify our facilities of interest. So where the three organizational surveys get much more complicated is for the clinician survey, we just go straight to the clinician to complete the survey. For the organizational surveys, we have to go to the organization first, get the organization's permission, and then so one option would be to just have the organization say, oh, here are like 10 of our staff that you can survey. That would make you concerned about like how representative is that staff? Are these like staff that the management like for some particular reason? And so what we've done is for participating organizations, we basically provide them a list of job titles that we're interested in and ask them to provide, these are our staff in those job titles, and then we randomly select the staff to actually complete the survey. We have just gone into the field in like late August is when the organizational fielding started happening. And so we're just at the very beginning of data collection starting to come in. And you could imagine, in a number of these cases, first, it takes a ton of phone calls even to get a hold of the administrator. And then once you get a hold of the administrator, oftentimes they can't give you an answer. They have to talk to whoever's above them. And so we're just at the point where data collection for these organizational surveys is starting to get underway, and we're getting some responses. In the case of assisted living, the assisted living survey, there isn't like Medicare claims or MDS assessments that we could use to create our sample frame. Instead, state by state, each state has its own way of licensing assisted living. And so James and his team at the Survey Research Center use state agency licensing lists in order to, and then similarly looking at the location of the agency, is it urban, is it rural? The bed size of the facility, to develop the sample frame, again, based on the state licensing information. Sample size for this one is around 15,000 over the 5 years of the survey. And that last bullet is around the linked data. That'll be a couple slides at the end. I'll talk about that a little bit more. So finally, the home care / home health staff survey. So this one, again, everybody on this call would be probably aware of this. This is the most challenging sample frame for us to build because of the nature of this workforce and the types of organizations and individuals who are doing this work. So in the first year, this really is more accurately, I'd say, a home health survey because the sort of most accessible source of data we have were what are agencies that are registered with CMS. Well, the types of agencies registered with CMS are agencies that provide home health care that would be reimbursed through Medicare. Now, some of those agencies that do provide home health also provide home care. And Joanne and James have done some work, lots of Venn diagrams, looking at the overlap in between home health and home care, and actually how that varies sort of state to state, what that overlap looks like. And in the survey, we ask upfront, like, what types of services does this agency provide? So my little asterisk a couple slides back on the survey is that in the first year, it's more of a home health survey, but we very much know it'll probably be a 5-year project to really truly turn this into a home care survey, but that is very much what our goal is over the next couple of years. So here are mapping out the strata across all 4 surveys together, where we have some proxy for the size of the organization or the patient panel. We have urban rural because again, we want to make sure that rural providers are represented. Some type of measure of socioeconomic disadvantage, um, some measure of geography. So, other thing to mention, the assisted living and home care surveys both are starting with around a sample of about 20 states. So they're the community clinician and nursing home surveys in the first year both really are drawing nationally. Assisted living and home care, again, because of the complexities of the frame for those two are starting sort of like half national, and then we'll get truly national in year 2. This is where Joanne really should be talking because she's the one who led the way on developing the surveys. I won't spend a lot of time on this slide. Hopefully, all of you know that if you go to our website, all of the survey instruments are available there. The goal was that these would be on the order of 20 to 25 minutes. So you could imagine there was sort of like a lot of jockeying for what content would make the cut or not. We'll be very interested to see the data that comes back about how long these really are taking to complete. Again, keeping in mind the varied literacy levels of the different populations that'll be completing the survey. And you all also probably know this, but if you didn't know, every year we'll do a call for additional questions. The call for the year two surveys closed, but please keep an eye out in coming years for the call for additional questions to add. And then I mentioned that there are administrator surveys. It's a little bit of a misname. It's really more like an organizational survey. We're not like serving the administrator about their job. To help us get a little bit more information about practice setting characteristics, the say type of training programs that a given organization offers, the type of benefits that they offer, questions that aren't really available in other types of organizational data sources. So now these are the last couple slides on the linked data. And again, I would refer you to the website if you want to learn more. The way to think about this is there's sort of 4 buckets of linked data. The most simple version is linking. So for the 3 organizational surveys, being able to link the staff respondent surveys from the participating organizations to the administrator survey. And you could imagine all kinds of things you might look at if you could combine those data. Um, and then there are sort of local context based on the geography of the respondent. There are claims-based summary files, and then beneficiary level CMS data that are available. And we'll talk a little bit more about these. So if you go to the website, this is where you'll find information about the data linkages and the questionnaires and all other kinds of stuff there. But data linkages are there under surveys and data. So when I talked about the geographic sort of environmental information available, so every respondent who finishes the survey, their survey data will go into the linkage platform where the linked data sources are available. And again, I'll talk about that in the next slide. They will all go into that environment with the FIPS state and county codes. So these are these federal standardized, like Washtenaw County, Michigan. I should know what the FIPS county code is. I don't off the top of my head, but Washtenaw has a FIPS county code. And then there's all kinds of linked data sources that you can combine if you know that FIPS code, including the area health resources files, which just has like thousands of variables in it around the supply of kind of every member of the healthcare workforce, hospital beds, home health agencies, primary care nurse practitioners per 100 population, just an enormous amount of data about the county. Something called the social deprivation index, which is sort of a composite of about a dozen different census variables to sort of get at the socioeconomic status of a given county. The AARP has this long-term services and supports state scorecard that gets into like how costly is nursing home care, what's the availability of again different types of like personal care services in your particular state. And then I don't have a bullet here, but there's a Medicaid expenses report prepared by Mathematica each year that has like a breakdown of a given state's expenditures on long-term services and supports, like how much goes to institutional nursing home spending, how much goes to home and community-based services. So those will all be available for linking with the survey data. And then the there's the potential for several of the surveys to link to actual beneficiary level Medicare, Medicaid claims and assessment data. So in the community clinician survey, if I were sampled for that survey and I completed it, my responses would my survey would be attached to my NPI number, my national provider identifier, which is what is basically the billing number that gets used when I see a patient with Medicare or when a patient with Medicare fills a prescription that I wrote. Because this will be available for all of the community clinician surveys, then you can actually link to all of the Medicare claims data for all of the patients that I provided care for or that I wrote prescriptions for. And so you could imagine that opens you to so many different research questions you can do by linking community clinician survey to the Medicare claims data of the patients that they provided care for, including things like I want to compare how clinicians prescribe to their patients with dementia versus their patients without dementia. You could also do that. Again, you have the NPI number, and so you can get all of the Medicare data for those clinicians. Similarly, for the nursing home survey, for the staff respondents from a given nursing home and the administrator respondent, their survey data will be linked with the CCN, which is, I think it's the CMS certification number, which is like the federal identifier of the nursing home. So once you have that, then you can get all of the MDS assessment data. So that's this minimum data set, federally mandated assessment that has to be completed on every individual when they're admitted to a nursing home. So you can identify everyone in MDS, all the individuals who received care in a given nursing home. And then once you have that, you can then get all of those individuals' Medicare or Medicaid data. So again, a very, very powerful tool to link the surveys to objective measures of care and costs of care using MDS data, Medicare data, Medicaid data. I didn't update this to reflect the fact that because in the first year, the home care staff survey, again, we started out with agencies that are registered with CMS. That means those home health agencies all also have a CCN. So similarly, just like with the nursing home survey, for respondents from a participating home health agency, you would be able to get all of their CMS data. Um, Within the linkage platform, we will have other data resources available that take advantage of either the NPI or the CCN. Things like the PBJ data, which is the payroll-based journal data for nursing homes who have to report their staffing and hours of staffing. So if you wanted to look at turnover or hours per resident day, you can do all of that by linking the surveys to the PBJ data. We'll have nursing home compared data available, and then also LTC Focus, which is out of Brown University. And then finally, for the community clinician and the nursing home survey, we've developed what we're calling claims-based summary files. So I don't know if if folks on the call have experience working with sort of raw CMS, Medicare claims data, or MDS assessment data, they are very complicated data to work with. And in most cases, you need to be working with, say, a data manager or analyst who has experience working with these data. So that's and only certain researchers on certain teams would have access to that type of technical expertise. So the thing about something like LTC Focus, which is out of Brown University, they have taken now for, I think, more than 20 years, have used MDS assessment data and have generated this nursing home level file that has all different kinds of quality and sort of patient demographic measures that they make publicly available. That is an enormous data resource. So people who don't have the capacity to sort of do raw data management on Medicare data, they can just download the data from LTC Focus and get like hospitalization rate, readmission rate, antipsychotic use, the rate of feeding tubes. All of that data is just ready for them to take it and run with it and do an analysis on it. And so we wanted to create something similar to sort of lower the barrier for patients to be able to link the surveys to, say, outcomes of patients with dementia. And so for the community clinician survey and the nursing home surveys, we have created or currently are working to create some claims-based summary files to get at just like, patient demographics. What's your panel look like? What's the racial makeup of your panel? Percent with Medicaid or low income subsidy? How far do your patients travel to see you? Um, what's that like? How many of your patients have you had a telehealth visit with? How many of them are enrolled in hospice? I think about medication a lot. So we have like the percent of your panel that's prescribed an antipsychotic or a benzodiazepine. And similarly, we've done that for the nursing home. So you might say, well, Donovan, LTC Focus already exists, and you're putting it in linkage for researchers to use. Why are you making this for nursing homes? LTC Focus is about all of the patients. And so for the data that we'll have, it will be limited to residents in nursing facilities who have dementia. For assisted living, there's not an easy way to do this because there's not anything like the MDS that exists for assisted living. However, some researchers have come up with methods where they use the 9-digit zip code of larger assisted living communities are big enough that they have their own 9-digit zip code. And so our plan for year 2 is that we will use this zip code trick to identify beneficiaries that way. And then we'll have these claims-based summary files available for assisted living as well. So in the home stretch, where will you be able to find these data? So there will be public use versions of the surveys, the individual respondent surveys will be available through this thing called NACDA, which is like the National Archive of Computerized Data on Aging, something like that. It's an NIA-funded enclave for aging-related studies. All you have to do is like just register, and then you can download, we'll be able to download our data. And then if you want to do any of the types of linkage that I mentioned, beginning again with the simple version of linkage, which is just the respondent survey and the organization survey, or then any of the other more complicated data sources that we went through, all of those will be done through this platform that NIA supports called Linkage. The aim is to have all of these data available in March of 2025. And the thing to highlight is all of these data are free. You don't have to get a pilot from us. It's free to anyone who wants to be able to you just have to register at NACDA and download it. For linkage, you have to apply and get it, but it's free. The other thing to note is that the CMS data is free. So if any of you have tried to do a Medicare project using the VRDC and applied through ResDAC, you know that it is incredibly costly and prohibitively costly for an early career researcher. So I'm just saying all of this data will be free, including access to the CMS data will be free. Already mentioned the pilot awards. The call is out. If you look for it on our website, deadline is November the 1st, but we'll be doing that annually. as we're trying to have as many resources available as we go. So you can say like look for us at a GSA meeting near you or Academy Health in the next couple of years. Um, and then we will, beginning in year three, we will start having sort of annual workforce NDWS data users research conferences, again, to help really try and build up the community of data users. Um, like I mentioned, data collection has begun. We're watching the numbers come trickle in. RTI, we're pleased to be working with on the community clinician nursing home and assisted living surveys, and then DLH is doing the home care staff survey. I mentioned about the pilot awards. I mentioned when the data is going to be available. And then I'll just end on this slide. If you're not already on the listserv, you probably all already are, but if you're not, please just send us a note and we'd be happy to add you. That's it. Thank you.
Thank you, Donovan. So we've got space in the Q&A for people to put in questions. I'm going to ask a question that I know you know the answer to because we talk about these things all the time, but not everybody else necessarily does. Um, you mentioned for home care, the first year is home health focused. Um, it'd be great to kick around some of the potential ideas that we have had about how to expand that population that might go beyond looking for state licensed agencies. And I know we also have Kezia here, so I'd love to hear any input that she might have if she wants to, pop into the conversation as well.
So we're while maybe Kezia is turning her camera on, so we are working with the Alzheimer's Association, and they have a number of different sort of stakeholder groups. Joanne over the summer talked to their kind of industry stakeholder group. This afternoon, I'm going to talk. They have a caregiver engagement group, and so one of the things that we're going to talk to them about is how have you found personal care, like to figure out from actual families how they go about, like what are the resources they use to try and track down. We figured asking the end users might be a way to help us think more broadly about how to track down some of these folks and organizations.
And I can just jump into with due humility because you all are really the experts, and I've just been privileged to be a little bit of part of your thinking about this. And I think it has just really exemplified the challenges of reaching this very diverse and dispersed workforce in home care beyond home health agencies, and sort of speaking to broader systemic challenges that we have in reaching this workforce and learning about their experiences and their expertise and their needs for support and so on. So I think what you're sort of trying to take on here is so foundational to the, or sort of central to the work that you're doing with this survey, but also kind of to broader efforts to learn about and intervene with this workforce. So I think it's an exciting set of challenges to try to grapple with. And I think what's also so interesting as you get to this sort of frontline workforce in supporting people living with dementia, it becomes harder to differentiate those who specifically support people living with dementia from those that don't, because often these workers have different clients or consumers, and some have cognitive impairment and some don't. And so it's sort of like you're zooming in, but then you're also broadening out the knowledge again, because a lot of the questions will help inform our understanding of this workforce kind of more broadly, and how their work is organized and who they're supporting, and what their training needs are, and all of those important questions.
That is a great point, Kezia. That perhaps we didn't, we should be making when we do a standard presentation of this is, for the clinicians who are surveyed, there are many questions in the survey about that are very specific to their practices and attitudes and knowledge about dementia care and referrals related to that. But there are also general questions about who else is in their practice. And and kind of what is their training, and do they have additional board certification or additional trainings, or, various other bits of information about them. Similarly, for nursing homes, there's information about not just the attitudes and knowledge that the worker has related to dementia, but also have they experienced an occupational injury? Have they experienced harassment in the workplace? And there are some questions about generalized training knowledge that they have. So for those of you that are interested in this workforce broadly and interested in their contributions to quality of nursing home care generally, there are opportunities to work with the data to focus on the dementia care aspects per se, but also more broadly, what's happening in nursing homes, what's happening in home care. Because these things are very deeply intertwined. If an organization has staff that do not feel empowered or have difficult work environments, that affects everybody who is a resident in that facility. And so so there's a lot more opportunity than just thinking about dementia care when you look at these data. So, and if people have ideas on chasing down direct care workers for future survey years, please email us. We would love to hear various ideas, and we're attentive to the notion that, you could do recruitment through social media, or, like targeted Facebook ads can get you a long way towards a population. But we also know that, honestly, survey fraud is becoming an increasing problem of people who are not direct care workers coming in and trying to claim that they are in order to get the incentives that are being offered for people to complete the survey. So if we do engage in those kinds of strategies to find people who might not be in agencies and might not show up in, training databases or state registries, we're trying to think about, like, then how do you confirm that they are doing the work that they say that they are, so that some fraudster doesn't take an incentive and provide data that undermines the quality of what you get, and is, we're trying to be very good stewards of the tax dollar here. So I'm still keeping an eye on the Q&A for additional questions. I imagine people do have other questions about what's happening with this, the linkages, the types of data that will be available, or any other questions. Kezia has a question.
Jump in while others are considering their questions. I don't think you spoke to this, Donovan, and if you did, I'm very, very sorry. But just thinking about revising the surveys for the next round of fielding, and I know you opened up for suggestions about additional items. I just wondered if you didn't speak to this already, if you wanted to say anything about kind of what you saw come in, and how you think the surveys may change accordingly.
That question is custom designed for Joanne to answer.
Perfect.
One more time, sorry.
About the survey items that came in, and what's our thinking on the new stuff that's being
Like
incorporated.
additional
Yes,
suggestions.
yes. We got some great additional questions that were suggested, and we're still in the finalization process. So we are going to send out communication to everybody who submitted ideas. But I think one of the areas that was submitted by multiple people that we are, and that we had discussed doing more with in our round one survey, is around experiences of discrimination and harassment in the workplace. And so there were several people who suggested different instruments, different batches of questions, just the general domain. And given that there were multiple people interested in that topic, and the great ideas that were more specific that came in around that, we have crafted a set of questions on that and adopted them from other surveys. And so those are now going out to our consultants, including you, Kezia. You'll get it today or tomorrow, to review and provide additional input. And then we will be taking those questions to cognitive testing to see how they work with an actual group of workers in the field. I think there are some other items that are going to be added that, that of course there's always items where you're like, oh, I wish we'd asked that in year one. We're going to ask a more detailed question about marital status. Right now, there's a question about who else lives in your home that's very generalized, like number of other adults, number of elders, number of children. But none of that doesn't specifically say like, do you have a, partner or spouse, or are you widowed? So that's going to be a specific question. And then we also are going to ask about household income. And that'll be in brackets. It's not a fill in the blank. It'll be in brackets, because in general, I think people find that response better in that. Um, Assuming it cognitively tests well, we probably also will specifically ask about private equity ownership, but we are going to test and make sure that, because that is kind of a little bit vague, right? You feel like you know it when you see it, but then if you ask, like, is your assisted living community owned by private equity? Can an administrator answer that, or would they need a broader definition, or kind of what would we need to do with that to get that information? So that one we're trying to explore how to get, because we know that you want that information for your research. It's a hot topic, but we're trying to figure out how to get it in a way that is valid, because there's not any external database for it. And administrators might say, well, what exactly do you mean by private equity? Because a lot of these organizations are privately held. So what's the difference? And we need to figure that out.
We're afraid of any question that might make someone feel like they need to leave the survey for a minute or go track down another answer, because then it's like maybe they won't ever come back. So
Yes, yes, yeah. There are some really nice questions that we're also pondering around, kind of the social determinants and household situation of the respondent. And we're trying to hit that sweet spot between getting a little bit more information about difficulties that they may face. Do they own their home, or rent their home? Have they experienced homelessness? Do they, et cetera. But, it's like hitting that sweet spot between getting information that might tell us more about the life circumstances of this workforce without them saying, wow, this is awfully nosy, and stepping out of the survey. So, that, and again, cognitive testing is the Survey Michigan Research Center, they've got such great people. And so they really are leading up the cognitive testing. They've got a really good eye to this. I mean, I think we will explicitly ask, like, do you feel like these questions are too nosy? If you were receiving this survey, would you feel like, would this make you think you want to step out of the survey? And just, I think we can ask that directly, but the Survey Research Center will know what techniques to use to best test those things. There are some other
Jo-
things suggested that are coming in, but those are the things off the top of mind, that we're going to add this year, and other things we're kind of keeping in the parking lot for round three.
Joanne, if you want to have a look in the Q&A,
Oh
I
yeah.
think,
The first
why don't you?
question in the Q&A is around languages spoken by the respondents, and we do have questions around language spoken by the respondents. And I think that there'll be some aggregation of that data in the public use files because of identification risk. Like, we anticipate that there will be a very large percentage that speak Spanish, and the surveys are fielded in Spanish for staff as well as in English. But languages that might be common in direct care, like Yoruba, or or Thai, or Tagalog, we still might not have enough respondents in that to be able to really include that variable with that level of detail in the public use file. And there is a document on the website that has the current plan about what variables are going to be aggregated and suppressed in order to protect identity in the public use files. But you would be able to get all the detail going through the linkage platform, which has another level of security for the respondents. Let's see, there is another question about knowledge, attitudes, and practices related to palliative care and hospice care for dementia care. That is an area that we are very interested in and thinking about primarily for year three, how we might expand both the sample frame potentially for clinicians to include hospice and palliative board certified clinicians that could be in year three or four, but at what point should we bring in that specific population? And then also thinking about it, like what would be a set of good validated questions for assisted living, nursing home, and home care that would address knowledge about palliative and hospice care. And so that's an area of interest. We have the great fortune of having Krista Harrison and Lauren Hunt on our team, both of whom have very strong expertise in that area and research interests in that area. So we're gonna, be taking advantage of their knowledge in thinking about how to expand out modules in that area. Other questions? We are approaching the end of our time, so if nobody else has questions, that's okay, but we're going to keep an eye on the Q&A box for a few more minutes. So as people know and has been said a few times, the Pilot Award RFA is out and running. Please share it with friends and colleagues and encourage people to take a look. We had an informational webinar about that yesterday that was recorded and should be posted pretty soon, that answered a number of questions that people had about the data and about the Pilot Award process. You can also submit questions to the email at NDWS, the whatever it is on the website, info at whatever it says on the website. You can email that address also, and the questions are getting routed to Sue Ann Bell and Laura Wagner, who are leading up that Pilot Award process. Anything else, Donovan?
No,
No?
I think we've covered a lot.
Yeah, so join us next month, everybody, for the post-election distraction of technology and VR in dementia care. I think it's going to be super interesting. A few years ago, I got to go to an Aging 2.0 technology conference, and I was disheartened at some of the technologies that seemed like people were developing that had not actually ever talked to somebody who had dementia. But then there was also a great, there also were some really, really cool technologies. And so I'm really looking forward to this presentation because I think some of the VR and some of the robotics and such may have some potential to really support people well. And then we had a question about the pilot project announcement. And Donovan put that link in the Q&A so everybody can see it. And if you can always go to www.ndws.org. And we think the website is very well organized, but if you have difficulty finding something that you're looking for, shoot us an email because that is always really good feedback for us to have to improve our communication. Thank you very much, everybody. I think this
Thank you
concludes
all.
this month's webinar. Thanks for being here, Kezia, and jumping in. And thank you, Donovan, for taking time this morning. I'll see Donovan in a meeting, I'm sure, tomorrow morning or something.
Soon. Yeah.
It's every day, every day. And
Always.
we
Yeah.
will see many of you online, I'm sure, soon. And hopefully we'll see you at the GSA meeting. We're really looking forward to seeing a lot of people in person there.